This week on Empowering Midlife Wellness, I'm talking about a really critical micronutrient, which is iron. Iron is involved in so many enzymatic processes in our body, not just making red blood cells. So I'm going to talk to you about how we optimize iron today. Hi friends, and welcome to this week's episode. If you're just joining me, I'm Dr. Susan. I'm a board-certified gynecologist and certified menopause practitioner dedicated 100% to taking care of women in midlife. That's women in perimenopause, menopause, and beyond. Women just like me who want to feel great now and also do everything we can to feel well when we're elderly, because that starts now. And everything I talk about has something to do with that. So today I'm talking about this really important micronutrient called iron. Now, I have a personal relationship with iron, having been diagnosed with very low iron recently and treating it and recognizing in my own body just how much better that feels. But I can tell you also on our patient population that if we use the standard that I'm going to present today, more than 50% of you listening today have suboptimal iron. And if you're still having periods, that's more like 75%. So suboptimal iron makes us feel crummy. And I'm going to talk about the symptoms of low iron shortly, but it could be one of the many things that's causing you to not feel optimal right now. So it's really important to look into, and there are some really simple blood tests. I'm going to tell you what they are. I'm going to tell you how to evaluate the results because unfortunately your doctor might not know. I certainly was not taught this in medical school. And then I'm going to talk to you about how to address it with food, possibly supplements, or even in some cases an IV infusion, whatever we need to do to make it better. So let's just start at the beginning. What is iron? Where do we find it? How do we get it? And why are most of us or many of us low in iron? Well, we get iron in our food, and the high iron food sources are things that you might not eat. I can tell you these are things that are not high on my list of dietary preferences. Things like red meat, beef liver, certain shellfish like oysters, clams, mussels, some other fun things like dried apricots, lentils, dark green leafy vegetables like spinach, but you need a ton of spinach to get close to your daily requirement of iron. If things on that list don't sound like things that you eat a lot of, like me, very likely you're not getting enough in your system in the first place. Now, the next reason can be because we don't absorb enough in our stomach, because the absorption of iron on a good day is only about 10% of what we take in. And there's lots of things that can make it even less than that I'll talk to you about. And then thirdly, we can be losing iron, primarily through menstrual bleeding if we're women, but also from other sources like microscopic bleeding inside our GI tract because of things like ulcerative colitis or even colon cancer. So we've got decreased intake, decreased absorption, or loss of iron through bleeding. Those are the three main sources of low iron. So let's dig into all of that a little bit more. So we talked about the foods where iron is found, and you might recognize that that's not a big part of your diet. If it is, it could still be low for those other two reasons. Another fun fact is if you cook in an iron skillet, you get some iron in that way as well, which is fun. But if your iron's low, and I'll talk to you about what that means in a moment, we want to evaluate each of those parts. First of all, do a nutritional inventory to see how much you're taking in. Talk about things that can affect absorption, and then evaluate for things that could be causing us to lose iron in the form of blood. All right, so let's go back to step one. We talked about those foods. Now, how much do we need? Just to maintain the status quo, we need 10 to 20 milligrams of iron a day. And for women, it's probably on the higher end, since many of us built a baby or two or three that sucks a lot of iron out of our system. All of us had menstrual bleeding for a long time. Many of us are not eating enough iron. So we think about being on the higher end of that 10 to 20 range. Now, let's just say you got 20 milligrams of iron in your diet. Now, that would be impressive, but you can if you try really hard. On a good day, you're going to get about 2 milligrams of iron that actually is absorbed into your system. The rest of it is passed through your stool back out into the world. So what can decrease absorption in our stomach? Well, some very common things like proton pump inhibitors. There's really commonly prescribed anti-acid drugs like Prevacid, Nexium, Prilosec. All of those cut down on acid production in the stomach. They have a whole bunch of other negative side effects that we can talk about in another podcast. They were never designed for long-term use, but in the short term, they cut down on acid, and iron is preferentially absorbed in an acidic environment. Now, another way we can decrease acid in our stomach temporarily is by eating dairy. Now, there's nothing wrong with eating dairy, but if you had your iron-rich food and had it along with dairy, it's going to neutralize some of that acid. So these are all very common things that could prevent us from getting the iron from the food that we're eating. Other things like gastric bypass surgery or other illnesses that disrupt the integrity of your stomach, GLP-1 agonists if you're on weight loss drugs, just a lot of things can prevent absorption being as high as it should be. And remember, even in a best case scenario, it's only about 10%. Well, let's just continue with this best case scenario. I'm feeling optimistic today. We took in 20 milligrams. We got 2 milligrams into our bloodstream. Well, then what happens? Well, our body's really good at taking it for the most necessary thing first. Now, iron does a whole lot of things. In fact, it's involved in more than 5%. Huge number of enzymatic processes in our body, but the one we might know the most about or think about the most in relation to iron is in making red blood cells, and it's absolutely vital for that very important function. So hemoglobin, which is the protein that red blood cells are made up of that carries oxygen around our body, requires iron to be formed. So without iron, we can't make hemoglobin. We become anemic. That means we don't have enough red blood cells. That compromises our ability to carry oxygen around our system, and everything starts to fall apart and eventually can lead to serious illness or death. Now, that sounds pretty dramatic, but iron deficiency anemia used to be the only tip-off that somebody had low iron. In fact, I was taught in med school that if your blood count was fine, you're not anemic, then your iron must be fine. And that's a very limited, small way of thinking. Just like other diseases where we were taught, unfortunately, that blood sugar was basically fine until you became frankly diabetic, which of course we know is completely false now. Similarly, we know now that you can have very low total body iron and still have a perfectly normal blood count because our body takes iron to replenish our blood cells first. So by the time we're anemic, we've had low total body iron probably for years. So anemia is a very late stage symptom that we're going to pick up in a patient with low iron. However, if you've got iron deficiency anemia, what we'll see is fewer red blood cells, so that means your hemoglobin is low. In women, hemoglobin, we want to be greater than 12, even 13 or higher would be great. Even when it's getting down to the 11s or lower, that is significant anemia that's going to compromise oxygen transport, and we're going to start being symptomatic. Once it gets down, in the 8s or lower, we need a blood transfusion. So, pretty small window of hemoglobin that we need to function optimally. We also see in patients who are seriously iron deficient and have developed anemia that the red blood cells actually get smaller. We call it microcytic anemia. They simply can't grow. They're skinny, they're thinner, they have lower density. There's a whole bunch of measurements of red blood cells when you do a complete blood count that look into the status of your red blood cells and could pick that up if it were there. But we really want to pick it up much earlier than that. So we're taking iron to replenish our blood cells first. That's great. Remember, going back to the story, we have 2 milligrams to play with here in this scenario, which is on the high side. Most of it's taken to replenish our blood cells. If there's some left over, and we sure hope there is, then it's put aside and stored in this fantastic protein called ferritin. Now, ferritin is an amazing gas tank for iron. It can actually store massive amounts of iron for 2 to 3 years, which is such an incredible thing, isn't it? Our body is so smart. So it takes any leftover iron and stores it in the ferritin protein. Now, when it's needed for use for all these other enzymatic processes, iron is toxic, so we don't want it floating around in our bloodstream freely. Very little iron is measurable in the blood. In fact, as a little deviation, it's not very useful to measure serum iron to evaluate someone's iron status because it's all bound, it should be bound to a protein. So once it leaves the ferritin, which is mostly in our muscle and liver for storage, that's a great place to store stuff, then a different protein called transferrin picks it up and carts it around and takes it to its target organ, which is great because it kind of hides it. It's covered in protein so that it's not toxic to our system during its travels. So transferrin is also really important to evaluate because we can check your blood count, and we should. So number one on the list is check your hemoglobin and look at the status of the red blood cells in the complete blood count, number one. Number two, check your ferritin. We want to have plenty of iron stored in the iron gas tank, so to speak. Number three, we want to look at what transferrin is doing. I'm going to tell you about some scenarios where we could be fooled by those two measurements, but all three of them together are rarely going to be able to fool us. There are some measurements of how occupied the transferrin protein is with iron. There's something called TIBC, for example, total iron binding capacity. If our TIBC is high, that means our iron is low, because iron binding capacity being high means there's lots of open spaces in the transferrin protein waiting to be occupied, and there's not enough iron to do that. Now, on the other hand, if your TIBC is low or adequate, that means there are not many open spaces on the transferrin protein. That means there's lots of iron sticking to it and being carried around, and the transferrin's pretty busy doing its job. What we ideally would want then is a high hemoglobin, greater than 12, a high ferritin. Now, side note, on your labs, remember, reference ranges are not optimal ranges. A typical reference range for ferritin will say 15 to perhaps 200. Again, a ridiculously large range. That is not optimal. If your ferritin is below 20, we're sending you to get an IV iron infusion. That's dangerously low, and at levels like 15, you're already developing anemia. That's compromising red blood cell production. So we do not want to be 15. Optimal for women would be greater than 50, or higher, up to 200. Now, there are some states where ferritin can be too high as a genetic condition called hemochromatosis, which affects about 1 in 300 people. But we're not talking about high ferritin today. That's very rare compared to 50% of us that have low ferritin. So we'll focus on that today. But 50 to 200 is a healthy range for women. Even 100 would be a better goal, but at least 50 for the ferritin. So if you're below 50, we'd consider it to be suboptimal. If it's below 20, we're really considering it to be something we need to work on in a 911 sort of way, because that patient is generally going to be symptomatic. Even a patient lower than 50 could be symptomatic. I'm going to talk about that in a moment. So we want ferritin to be 50 or higher, and we want the TIBC to be low. That means the transferrin is largely occupied with iron and doesn't have a lot of open spaces. So low TIBC, if we just look at that reference range on the low end, not on the high end, it's very unusual to see someone that falls off the scale for a TIBC because the range is so ridiculously broad. Anyway, so an average patient, like perhaps you or me, I'll tell you what my labs were like a few weeks ago. My hemoglobin was perfect. It was 14. My red blood cells looked perfectly healthy on the CBC. My ferritin was 15, and my TIBC was way on the high end. So even though I was replenishing my blood cells appropriately with the very small amount of iron that I was eating, I didn't have any left over to be stored in the iron gas tank, that's ferritin, and my transferrin protein was running around with nothing to do, with lots of open spaces. There are some additional measurements that you can look at to assess the transferrin protein a little bit more, but honestly, TIBC is adequate. That's going to give you all the information that you need. Now, my story I'm going to tell you at the end, I did actually get an IV iron infusion, and I will tell you about how that works. That's an option that we reserve for patients with really critically low ferritin like mine, but it does eliminate any symptoms coming from low iron. So, what are symptoms of low iron? If your ferritin is very low, less than 20, you're probably experiencing some compromise in oxygen transport, even though your hemoglobin is normal, which is something that we're not taught in med school. I'm an athlete, as many of you know. I was noticing my resting heart rate was a little higher. I wrote it off. I'm like, maybe it's just getting hotter. The way we blow stuff off, I'm like, maybe I'm just having a low-grade virus or something like that. But it was sort of ongoing. My resting heart rate was starting to creep up. When I'm running, my heart rate was a little higher than usual. I wasn't getting better at running as fast as I usually do during my training seasons, just not feeling as good as usual. Even my heart rate during sleep was a few points higher than it had been in the past. So kind of vague feelings of fatigue are common. Some patients have restless leg syndrome. Some patients have hair loss. Some patients have palpitations. There's a lot of vague symptoms which sound a lot like, oh, you're just getting older, or maybe it's just menopause, or maybe it's part of your low thyroid, which are intimately involved. As I mentioned, iron's involved in a whole bunch of enzymatic processes, very much including your thyroid function. So low iron and low thyroid often go hand in hand. Mine was low. So all of these things sound very much like 100 other things and can be easily blown off, which is one of the reasons why it's not always looked into. If your doctor said, oh, your blood count's fine, so you must be fine. No, dig a little deeper. Measure those labs. Now, one more really interesting lab that's important to throw into this picture is something that assesses your state of inflammation. Now, if we're in a state of high inflammation, we often see an elevation in a blood test called C-reactive protein. So now we measure something called high sensitivity CRP, HSCRP. It's generally elevated when we're in a state of inflammation. And inflammation is a very vague term, as you know. That could happen when we're experiencing an acute infection, we've got a virus, maybe we're eating a lot of inflammatory foods, having a flare of an autoimmune condition, extreme emotional stress, lack of sleep, so many things. If our CRP is elevated and we're in a state of inflammation, iron is an acute inflammatory marker. So our ferritin is actually going to be pushed up falsely when we're in a state of inflammation. So if your ferritin looks fine and you're feeling in a state of inflammation, it might be because you are, and your ferritin is actually a lot lower than it looks. So typically we will always measure CRP along with ferritin and put them together to really understand what's going on with the patient. So just as a review, the important labs are a complete blood count, hemoglobin greater than 12, ferritin greater than 50, total iron binding capacity should be low, on the low end of the reference range for your lab. I'm not going to give you numbers because there are different ones for different labs, but on the low end. And then C-reactive protein, highly sensitive CRP should be hopefully less than 1. So that would be a perfect picture for iron balance. Now, if it's not perfect, if it's low, what do we do? Well, first of all, we evaluate the nutritional component and see if we can improve the amount that you're taking in. Now, if you're not going to change your diet, and I'm in that group, I was not planning to start eating any of those high iron foods, I started taking an iron supplement by mouth. A couple that are really popular, there's one made by Thorne that I take called Ferrazorb. Now, it's easily absorbed, hence the name. They did a clever thing, which was putting vitamin C in it, so that elevates the acidic environment in the product itself, so it's easier absorbed. It manages to bypass some of those other factors in the stomach better than some products that don't have that in them. So Ferrazorb has about 35 milligrams of elemental iron. So remember, we need at least 20 just to kind of keep the status quo. But if our ferritin's very low, we need a lot more than that so we can push the iron into storage and elevate our ferritin. So about 30 to 40 milligrams a day in a supplement is a really good amount. Of course, we don't know how much of that we're going to absorb, but something like Ferrazorb does optimize absorption. Another popular one is Slow Fe. You can get that over the counter at any drugstore. It has about 40 milligrams of elemental iron. It's slowly released, hence the name, and some people find it's a little bit better for GI side effects. So a couple of products that you might try. So then we would give the patient iron, just like I took, for a few months and then check it again. It takes a long, long time to rebuild ferritin because it's just a tiny little bit every day that's getting in there. Again, most of it's being used to replenish your blood cells, and a little bit is put in that ferritin protein. So it's a slow process. In my case, it didn't really help. Probably something to do with me not absorbing it very well because I was certainly taking in enough, and my ferritin did not improve. And so then we went to the next step that I'll discuss in a moment. So first of all, we deal with nutrition, try to increase what you're taking in, try to bypass anything that might be happening in the stomach that's reducing absorption. Now, while we're doing all that, we need to really evaluate if there's any source of blood loss that we might not be aware of. Now, if you're a menstruating woman and you're having really heavy periods, it's going to be a bit of a losing battle trying to improve your ferritin by taking iron when it's just coming out the other end. So it's critical in that scenario to do everything we can to reduce the amount of blood that you're losing. So number one, reduce apparent blood loss. And number two, let's look for any microscopic blood loss that might not be evident to the eye, and that's usually in the GI tract, or I would just say always in the GI tract. So colonoscopy to rule out colon cancer, ulcerative colitis, anything else that could be causing the GI tract to be losing blood. So again, we want to analyze what we're taking in, how we're absorbing it, and any source of loss. Now, once we've replenished it up here, we've dealt with the stomach, nothing is happening. If our ferritin is less than 20 and our TIBC is really high, on occasion, we might go to the last step, which is to use an IV iron infusion. And as I mentioned, I had one last month. So iron infusions used to have a really bad reputation. I mentioned already that iron is toxic, and it is. However, when it's given through an IV iron infusion, it's very rapidly picked up by protein. It's taken out of our blood and stored in ferritin in a number of minutes. It happens very fast. So we do not experience toxicity from getting IV iron in that way. When I was in med school, the idea of iron being toxic was very prevalent. And so an IV iron infusion was something that you basically never did unless the patient was on death's door. We would give a blood transfusion first. I was taught that you had to have an infusion done in a hospital setting with cardiac monitoring. And, we were really worried about the effects of doing this. I'll just say now, this is 25 years later, the process has been, pretty worked through. So you can get a very safe IV iron infusion. It takes about 20 minutes. It's done in the doctor's office. Very rarely do patients have side effects from it. Now, occasionally patients will have a little itching, can feel a little body aches, just a little discomfort. I didn't have any of those things, and our many patients who've gone through this process, they didn't either. However, it is something that the hematologist who performs this procedure for you will walk through with you very carefully. So it's not something that you want to do just to get more energy or to feel better. We only want to give it to patients who really do have critically low iron stores, like me. It took about a week, and my heart rate was lower, my exercise tolerance was better, my heart rate even at night while I was sleeping was lower, more energy. So the symptom relief can be quite apparent when it's been really critically low. Patients describe better thinking, less brain fog. If they had thyroid dysfunction, that often gets better. If they were frankly anemic, well, their energy goes through the roof because now they're able to actually carry oxygen to their brain and every cell in their body. So fixing iron deficiency is critical for feeling well and functioning optimally. Obviously, if our iron's really low and we feel tired, we don't exercise, we lose muscle mass, we gain weight around the middle. So it can lead indirectly to a whole bunch of other unpleasantries. So I'm going to show you a little video of me getting my iron infusion. It really was so easy. Our wonderful friend, Dr. Luis Camacho here in Houston, does the iron infusions for us when patients qualify for them. He does require all of the blood work that I talked about, so he can evaluate you critically to make sure there's nothing else going on. And if you do fit that picture for being very iron deficient, that could be an option for you as well. So not for everybody, but certainly beats a blood transfusion. And that would be the next step after that. So let's think about iron as one of the more important micronutrients in our system. They're all important, but that's one that's so prevalent in being low. As I mentioned in the beginning, more than 50% of us have suboptimal ferritin, and it's so easy to correct. Not usually with an iron infusion, usually with a simple supplement or even just with nutrition and cooking in an iron skillet. So that's what I have to say about iron today. I hope you enjoyed it. Please subscribe, write some comments, let us know what we're doing well and what we can improve. Share it with your friends, and I can't wait to see you next week.